Ladies and gentlemen, good afternoon. First of all, I would like to thank you a lot for inviting me in this outstanding meeting. I can see many European speakers and also our ESMO president, Professor Solange Peters. It's really my pleasure to be with you today, this lecture, but I will attend the post-session for questions and answers. I will discuss about a topic that is not so common. It's management over too low breast cancer. As you know, I work in Milano, in the University of Milano, and in the European Institute of Oncology in Italy. So those are my disclosures. So let's start discussing on how to treat the breast cancer. We listened to the lecture of Professor Peter Schmidt. Of course, I am quite sure you would agree with me that we have a state of art for luminal cancers. In this case, it's a Van Gogh, finally, in which we have the standard of care related to the use of CDK4/6 inhibitors plus endocrine therapy in the frontline setting. We have a state of art for HER2-positive breast cancer, in which you would agree with me that we have some standard of care that dramatically improved overall survival in those patients. First line with pertuzumab and trastuzumab, and then a second line with trastuzumab deruxtecan. We have also a state of the art for the triple negative disease in PD-L1 positive, the combination of atezolizumab plus chemotherapy, and in BRCA mutant, the opportunity to use, of course, the PARP inhibitors. But what's about their too low disease? You would agree with me that there is no painting, finally, that can summarize how to treat an HER2 low. So that's why I would like to discuss with you on the concept of HER2 low disease. Pivotal observations in the 80s showed that a subset of breast cancer harbored amplification in HER2 oncogene. Of course, there is an heterogeneity on the level of amplification, because every time we discuss about HER2 low, we are discussing about an HER2 heterogeneous breast cancer. These amplifications induce a marked overexpression of HER2 receptor, leading to a more aggressive behavior of disease. And we have trastuzumab and pertuzumab that can target that specific receptor and can dramatically improve, of course, the treatment of this disease. HER2 positive disease showed an exquisite sensitivity to an HER2 agent, and we had a revolution in this setting that can be summarized with the final update of the Cleopatra trial. You should consider that with the combination of pertuzumab, trastuzumab, and taxanes, after 8 years of follow-up, we have still 37% of the patients that are alive. That is a clinically meaningful benefit in this patient population. And we have 17% of the patients that never progressed. So, Jose Baselga, past ESMO president, did the pivotal trial in the metastatic setting. And together with Slamon, I believe they did really a revolution in this disease. And unfortunately, Jose died on March 21, and I believe we have to remind him on the pivotal phase 1 study that he did for the development of trastuzumab. Their two revolution is, of course, also very important in the adjuvant setting. You know very well that in node-positive disease, the combination of pertuzumab and trastuzumab impacted on overall survival of patients with a 6-year overall survival benefit of 90%. It means that we can really treat and cure those patients using entire HER2 therapy. Nowadays, we have 8 entire HER2 agents that are approved by EMA or FDA for HER2 positive disease. And moreover, 4 of these have been approved in a single year, from December 2029 to December 2020. What's about HER2-low disease? So conversely, we have HER2 positive disease, that is HER2 3+, according to immunohistochemical definition, or HER2 2+ with a FISH amplified. All the other patients, if they have a tumor that is not HER2 3+ or FISH amplified if HER2 2+, is HER2 negative. And the ASCO, of course, guidelines, ASCO CAP guidelines, clearly tell you that you should test all patients that are immunohistochemical 2+, so equivocal, and if FISH amplified, they can be treated with an entire 2 agents. So what we call HER2 negative cannot be defined immunohistochemically really as HER2 negative. Because if you look to HER2 1+ or HER2 2+ with FISH not amplified, you can see here that you may find in immunohistochemical detection an expression of HER2 receptor. And this expression can be used, of course, potentially to target with new agents. But since we have no activity from currently available entire 2 agents, we don't have any agent approved for HER2-low disease. Why this? Because we have evidence from several trials. When we observed the data of the HERA trial, HER2 status and benefit from adjuvant trastuzumab in breast cancer, the central analysis of all the HER2 assessment in the sample size of the tumor samples, 10% of the patients have no amplification of HER2. And in the context of the study and the analysis, these patients appeared to have a marginal benefit from adjuvant trastuzumab when we analyze finally those data. So if you look here, we have very limited patients, of course, but there is a trend for benefit with no statistical significance, finally. We have a prospective randomized trial that finally assessed the role of trastuzumab in so-called HER2-low disease. And this is the NSIBP-B47. The NSIBP-B47 randomized patients with HER2-low, so immunohistochemical 1+, 2+, with FISH non-amplified, to receive in group 1 chemotherapy alone, and in the group 2, chemotherapy plus trastuzumab. So the history of HER2-low, it's a very long history. And in the context of this clinical trial, there was absolutely no benefit from the addition of trastuzumab in the adjuvant setting. So if you look the curve in HER2-low, in terms of invasive disease-free survival and overall survival, there is a complete overlap between the chemotherapy arm and the chemotherapy plus trastuzumab arm. And looking at the data in the context of the box plot analysis, finally, they are inconsistent. Doesn't seem that you have really a benefit from trastuzumab. Similar results have been shown also in the metastatic setting. So this was an open-label phase 2 multi-center randomized trial of efficacy and safety of 2 dose levels of pertuzumab in HER2 positive disease, including also HER2-low. And the overall response rate was 2%. So it seems finally we have really a huge evidence that in HER2-low disease, you cannot achieve any type of benefit from an entire 2 therapy, both in the early setting and in the metastatic setting. So what to do now? But, you know, there was an opportunity. It's like a phoenix that will have a new birth finally following the end of this history. Because in ASCO 2028, we saw for the first time some data with trastuzumab deruxtecan in patients expressing HER2 in solid tumors. And it was interesting that in this study have been included both patients that were HER2 3+, or patients with HER2 2+ and FISH amplified, but we had also patients with HER2 low. So with immunohistochemical 1+ and 2+ and FISH not amplified. And in this patient population, included in the context of a phase 1 study, there was a 37% response rate. New study came from the evidence of trastuzumab deruxtecan. Another study was the phase 1 study with the trastuzumab duocarmazine, another antibody drug conjugated. And also here, response rate in HER2 low was between 28 and 40%. So there is a new hope here. We have the opportunity with a new generation antibody drug conjugate to target HER2 low disease and to demonstrate a potential activity. In the final analysis that has been presented also during the ASCO 2021, it seems that in HER2 low disease may work also potentially a vaccine. And here we have a prospective randomized trial for patients with HER2 low expressing breast cancer. And in the HER2 low, there is, with this vaccination strategy plus trastuzumab, a potential benefit. Very small study, of course. So one coincidence is just a coincidence, but two coincidences are a clue, and three coincidences are a proof. That's why maybe we need to generate more evidence on how to treat HER2 low disease. Why we need more evidence? Because from HER2 negative, we are now moving to understand which is an HER2 low. And in 2020, we organized in my institution an international panel of breast cancer experts to better understand what is an HER2 low disease. And the panel included people from all over the world, finally, and we tried to explain from a pathological point of view and from the clinical landscape, of course, if we have any opportunity to improve the activity of HER2 therapy in the HER2 low disease. Which is the HER2 low definition? We have several different definitions, but the most common definition of an HER2 low disease is a tumor with a low expression of HER2 by immunohistochemistry that can be 1+ or 2+, with an HSA that is negative. So HER2 low disease account from 35 to 55% of patients with HER2 positive breast cancer. And which is definition 45 to 55 can be considered HER2 low. So what's about HER2 expression and hormone receptor expression? I believe this is really an important point. If we consider HR positive disease, so patients that usually are treated with endocrine therapy plus CDK4/6 inhibitors, HER2 low account for 85% of the patients. If we consider the triple negative HER2 low, they are 15% of the patients. But if we consider HER2 according to RNA expression, we will discover that higher HER2 mRNA expression can be found in HR positive disease, specifically in those HR positive HER2 low. And so here we have another important observation that HR positive HER2 low are the more common patients in the context of this population. What's about HER2 low biology? We know very well that there is a crosstalk between estrogen receptor and HER2. And so maybe HER2 low can be a mechanism of endocrine resistance. And the clinical behavior is or is not different when we compare HER2 negative versus HER2 low. There is finally a very similar biology. HR positive are mostly luminal at a gene expression level, and triple negative are mostly basal-like at gene expression level. And what about prognosis? Looking at the data in patients with HER2 low, and we have several setting of data, it seems that prognosis of HER2 low, it's very similar to the prognosis of HR positive HER2 zero. So it seems not a prognostic factor, HER2 low expression, when we evaluate it according to immunohistochemical expression. But is there the opportunity to target HER2 low population with new agents? Of course, we don't have a standard of care. HER2 low are not reported in the treatment algorithm, but we know very well that you can use antibody drug conjugate because they can target also very low expression of HER2, and they can deliver directly chemotherapeutic agents in the context of the tumor cell. So it's not actionable, but potentially is targetable. And this is very important because we have several agents that can target low expression of HER2. One, of course, is TBM1 that has been explored in the context of HER2 low disease, but with a very low activity. The overall response rate was 5%. But we have also new generation of antibody drug conjugated like trastuzumab deruxtecan with a very stable linker, a very high payload, and of course the opportunity to target those cells. We have trastuzumab deruxtecan and trastuzumab duocarmazine. With trastuzumab duocarmazine, we have activity in the context of a study, including 49 patients that have been heavily pretreated with HER2 low expression. And in HR positive HER2 low disease, the activity of trastuzumab duocarmazine demonstrated a 28 response rate percentage, and in the triple negative HER2 low, an overall response rate of 40%, with a median progression-free survival of 4 months, and as potential toxicity, ocular adverse events, and as you know, inflammatory lung disease. With trastuzumab deruxtecan, that is an antibody drug conjugated, that is, of course, conjugated with deruxtecan. The study, of course, is more structured. That's been published by Shanu Modi on the JCO. Trastuzumab deruxtecan was tested in 54 highly pretreated HER2 low breast cancer patients with an overall response rate of 37%, with activity in both immunohistochemical 1 plus and 2 plus, and the median progression-free survival of 11 months. Also in this case, the potential safety concern is related to inflammatory lung disease. So, inflammatory lung disease can be managed, of course. If you have a grade 1, you can give oral prednisone until recover, and then you can restart treatment. What is important, of course, is to recognize the early ILD and to be careful in order to avoid a fatal evolution. You know very well that in the context of DESTINY-3, the rate of grade 4 and 5 was 0. And looking at the data of trastuzumab deruxtecan in HER2 low, you will see here that the majority of the benefit was observed in patients with hormone receptor 7 positive disease. And this is an important observation. So next step is to evaluate trastuzumab deruxtecan in a large randomized trial. And we have 2 trials, the DESTINY-04, in which patients with HER2 low disease, HR positive, no prior CDK4/6 inhibitor versus prior, have been randomized of trastuzumab deruxtecan versus physician choice regimen. And in the DESTINY-06, we have patients HR positive who never received chemotherapy that are randomized 2-to-1 to trastuzumab deruxtecan to physician choice treatment. Those are very important trials that can really demonstrate that trastuzumab deruxtecan is better respect to chemotherapy. Another important point is to redefine HER2 low definition. Of course, we have definition of immunohistochemical 2+ and 1+, but we may have also the so-called HER2 ultra low or HER2 null, in which you have from 0+ to less than 10% potential expression of HER2. And those patients are included in the DESTINY 6. Recently, we saw also the data of the DAISY trial, and among 37 patients, 30% had an objective response rate with trastuzumab deruxtecan. So it's important, in my opinion, to move from a binary expression of HER2, so positive versus negative, to an expression of HER2 as a spectrum of expression, more closer to the tumor heterogeneity, where you can access also HER2 with immunohistochemistry, with RT-PCR. So look at this finally as a continuum scoring from 0 to 3+, from 0 to 100%. So in conclusion, about 50% of all breast cancer are HER2 low and show low expression of HER2 with absence of HER2 amplification. Currently, HER2 low cancer do not appear biological or prognostically different from HER2 negative. But these low HER2 expressions can be exploited therapeutically through the delivery of payloads or immunocells. And large phase 3 randomized trial like the DESTINY-04 and the DESTINY-06 are ongoing to confirm the paradigm of HER2 low targetability. And if this paradigm will be confirmed, a redefinition of HER2 interpretation is anticipated, moving beyond the binary paradigm and toward a spectrum of expression. And so novel quantitative HER2 testing method may help in the refinement of HER2 classification. So thank you very much indeed, and I will be very happy to take questions.